COVID-19 era. Are you hearing me, سامعني?
Yes, we can hear you.
Okay. So I'll go through the introduction and definition and etiology as a routine. I'll go to try through symptoms and signs, how to differentiate between COVID and heart failure, and how we can diagnose it. And then at the end, I will conclude with the management. As of yesterday, the COVID-19 affected almost more than 2 million people worldwide, and the death rate is almost 7%. And and this is indicating that this is a serious issue, and people have to take it seriously. And just few points to mention before I go inside the talk. Cardiac involvement has been described in patients with severe COVID-19 disease, and there is increasing evidence that suggests. Abdulazim? Abdulazim? Hello? Hello?
We can hear you very well.
It looks like you're not moving the slides because I'm just reading from my computer. Go to the COVID-19 and heart failure so that people can follow me. Yes, and then next. Okay, here. And we said that the cardiac involvement has been described in patients with severe COVID-19 disease, and there is increasing evidence to suggest that the cardiovascular involvement portend to higher mortality. Despite improvement in the management of heart failure, still the heart failure remains a condition that as most as the common cancers. So the heart failure itself is not an easy disease. Go to the next slides. Go to the next slide, please. Yes. The cardiovascular complications because of the viral include the myocarditis, acute myocardial infarction, and it can exacerbate pre-existing heart failure, and even it may lead to arrhythmia and sudden cardiac death. Can we go to the next slide, please? And the cardiac involvement is common in COVID disease, and cardiomyopathy with COVID may result from myocarditis or profound systemic inflammation or by microvascular dysfunction. And the evidence of cardiac involvement is associated with poor prognosis in COVID-19 patients. Can we go to the next slide, please? Cardiac diagnostic. Okay. Cardiac diagnostic imaging and laboratory testing may be useful in certain patients, but always we have to weigh the risk against benefit and whether additional testing will result in change in management should be always considered. We should not forget that the guideline-directed medical therapy is very important to be continued in ambulatory patients who are hemodynamically stable and have no contraindication. Experimental strategies, including antiviral, anti-inflammatory, convalescent sera, are being considered as a part of research protocol in COVID-19 infection with or without cardiac involvement. Those with underlying cardiovascular disease are particularly susceptible to cardiovascular complication, and mortality with COVID-19 is extremely high. So the COVID itself has high mortality rate, and if you add the comorbidities like cardiovascular disease, the mortality rate even is becoming worse. If you want just to define that, what is a heart failure or what's acute heart failure? Acute, go to the next slide, please. Acute heart failure is a rapid onset or worsening of symptoms and sign of heart failure. It is a life-threatening medical condition which require urgent evaluation, treatment, and typically lead to urgent hospital admission. This is from European Society 2016. Go to the next slide, please. And generally, when we say the heart failure from 2016 at European Heart Failure meeting, they announced that the division of heart failure should be considered into 3 categories. We look for the ejection fraction mainly. If ejection fraction is less than 40% with the heart failure, we call it heart failure with reduced ejection fraction. And if it is between 40 to 49, this is called mid-range. And if it is 50 and above, it is called heart failure with preserved ejection fraction. In case of heart failure with reduced ejection fraction, you need just symptoms and sign and ejection fraction less than 40%. But in case of mid-range reduced ejection fraction or preserved ejection fraction, in addition to ejection fraction, you need to have high elevated natriuretic peptide. You need to have at least one additional criteria from relevant structural heart disease, like our left atrial enlargement or diastolic parameters should be consistent with findings with in addition to the ejection fraction range. Can we go to next slides? Next slide, please. Yes. We know that the heart disease is #1 killer. This is statistics from the week of April 6 to April 12, worldwide. If we look here, heart disease is #1. The second most is COVID-19, and almost is reaching the heart disease in 1 week time. So we're expecting in this week's or the previous week that even it may overseed, or it is the death rate from the COVID-19 is more than heart disease itself. So this is I got it from US statistic. I need more confirmation. We go to the next slides? Okay. Patient with acute heart failure. Either they are de novo, and we mean by that it is a new onset acute heart failure, or somebody already have heart failure with pre-existing condition, had acute decompensation. And in fact, what is called acute decompensation in chronic heart failure is not really true. Usually it is subacute, which is gradually progressed to acute heart failure. Can go with the next slide, please? Okay. What is the etiology? And I think all of you are aware of the etiology of heart failure. It is ranging from ischemic heart disease to toxic damage. And next slide, please. And here is the main thing we related to our topic is related to infection. Infection through different mechanisms can lead to the acute or exacerbation of chronic heart failure, like COVID-19 viral infection. Go to next slide, please. And usually there is, in some patients with chronic disease, or even with no heart failure, there is usually pre-existing cardiac disease, or there is multi-organ involvement, or there is pre-existing cardiac or non-cardiac disease. Go to the next slide, please. Okay. And in patients with chronic heart failure, decompensation usually is triggered by multiple factors, from acute coronary syndrome or tachyarrhythmias, or even high blood pressure. And in our case, usually infection and pneumonia is a triggering factor for the acute decompensation in case of chronic heart failure, or acute de novo heart failure itself. By itself, it can lead to acute decompensation. Next slide, please. Okay, how the COVID-19 cause acute or exacerbation of heart failure. There is different theories and different mechanisms which were suggested, including the plaque rupture, and that may be presenting with STEMI. And it can come also through the cytokine storm, which is related a lot of cytokine in the circulations, or it may lead to strong systemic inflammatory response, and also with the damage to the lungs, may have hypoxic injury, which can cause type 2 myocardial infarction and increase the workload of the heart, or through the coronary spasm and the microthrombi theory is gaining a lot of ground in this COVID-19 era. Next slide, please. And also the COVID-19 could cause damage to the myocardium through direct endothelial or vascular injury. And we know that there is receptors, ACE inhibitors receptors in the myocardium as well as the lungs and other vascular tissue. And typically in case of myocarditis, they see through the cardiac MRI, they see there is edema has been shown on magnetic resonance imaging in such patients who develop myocarditis. Next slide, please. Okay. This is here cases of myocarditis, cardiac involvement in patients with coronavirus disease, 2019. It was published in JAMA as a brief report. Next slide, please. And STEMI, as also mentioned in the New England Journal of Medicine, and this was the brief review of 18 patients in whom there is ST elevation. And in fact, not all ST elevation, there is obstructional or flow limiting disease. Some of them, they have a cath, and even the coronaries are patent, but still they have STEMI. So probably this is through direct damage to the myocardium. And next slide, please. Okay, next slide, please. Is it easy to diagnose heart failure in patients with COVID-19? No, it is very difficult to diagnose. There is a lot of similarities, and there is also differentiating point, which we will take it. And the X-ray sometimes is not helpful to differentiate, but we will use all our parameters, the laboratory testing, investigations, in addition to our clinical sense, which is gradually decreasing in presence of echoes and further cardiac testing. Next slide, please. This is from the Canadian Cardiovascular Society. They suggested for the rapid response team features that would some feature that would differentiate between the two. Here are some features that would increase the probability of COVID-19 versus heart failure. In favor of COVID-19, there is increased contact. If there is increased contact, this is in favor of COVID-19. Presence of fever or viral symptoms, this is in favor of COVID-19. Absence of typical heart failure features like paroxysmal nocturnal dyspnea, BND, these are, if they are absent, this is in favor of COVID-19 infection. And in fact, sometimes may coexist both together. Lack of response to appropriate heart failure therapies, if you are giving diuretics and patient is not responding, not improving. Is the biomarker is helpful in differentiating? No. You can have a biomarker in COVID-19 without even heart failure. Measuring blood pressure and heart rate at home, including oximetry from personal devices, cannot really differentiate between COVID-19 and heart failure. This is all done through telephonic conversation or virtual clinic. And usually they do assess the symptoms of a patient or progression in 24, 48 hours. Next slide, please. And here, this is guidance from the Canadian Cardiovascular Society, COVID-19 Rapid Response Team. Their question first, is it heart failure or is it COVID-19? So we take a history, travel history, social distancing, if it is insufficient, positive contact, personal, this favor COVID-19. And we have to take the duration and symptoms and weight to differentiate between the two. So if the symptoms with fever and travel history and contact and no social distancing and personal care is poor, this is in favor of COVID-19. Fatigue and cough and dyspnea cannot differentiate between the two. Edema, ascites, and weight gain, significant weight gain in favor of heart failure. Next slide, please. And here we have the typical symptom, and I think all of you are aware of it. to differentiate between heart failure or to diagnose heart failure by the clinical. Typical symptom, we know that breathlessness, orthopnea, although the breathlessness can be seen in post-COVID-19 or heart failure. Orthopnea usually and paroxysmal dyspnea is usually for the heart failure. And others are aware of it, and clinical examination looking for the JVB and hepatojugular reflux and the third heart sound, which is rarely checked by the cardiologist nowadays. There is less specific. I'm not going to talk about them. Next slide, please. Okay. If we want to diagnose, we look for the symptom and sign of left heart failure, like orthopnea, paroxysmal nocturnal dyspnea. In examination, also we look for the JVB, which is indicating right-sided heart failure, and we look for lower limb edema, hepatojugular reflux, and we also look for symptom of hypoperfusion, cold extremities, low pulse pressure, hypotension, mental confusion, and sometimes you have bradycardia and even tachycardia. And patient may be very dyspneic in both situations. Next slide, please. Next slide. This is just definition for oxygenation, hypoxia, and hypoxic respiratory failure. And we go to next slide, please. So to diagnose heart failure, you need to take a good history, you need to have a good physical examination, and you need to have laboratory tests to help you. And for diagnosing the viral infection of COVID-19, we need to do PCR, ECG, X-rays, and echo, and further testing is depend upon your findings. But always you should look for the safety of your staff, and always in such cases you have to use a PPE, personal protective equipment, and should be very careful about your machine cleaning so that you cannot make a cross transmission of infection between your staff and in hospital transmission. Next slide, please. And when we talk about the management of acute heart failure, always we put in our mind prevention, especially in such COVID-19. And there is an active treatment. Go to the next slide, please. So as we are doing here to reduce decompensation of chronically stable patient, we have a virtual clinic, okay, through the phone call or through WhatsApp, and the culture of hygiene, etiquette, and infection prevention society is very important for prevention. And in the hospital or a crowded area, people should be covered, at least wearing masks. Symptomatic heart failure patient should be recognized an extremely vulnerable group who should be shielded. Yani should not have a chance to mix with the people at home, stay away from people, because these are like immunocompromised patient. Go to the next slide, please. The treatment is different from the patient with heart failure and COVID-19. Is it different from the routine? No, I don't think so. They're similar, except for addressing the causative viral infection, the COVID-19. There is a lot of research and studies going on, and a lot of empirical treatment is being given. Go to the next slide. And the management usually in the first phase in acutely ill patient is usually supportive care. And currently there is no evidence to direct management of this patient differently than any other inflammatory or mixed shock state. Next slide, please. Okay. And in acutely ill patient in ICU or CCU setting, what is our target of management? We should keep the CVP between 6 to 8 millimeter of mercury. And in case of RV dysfunction, we have to keep a slightly higher preload between 12 and 15, the CVB. And the target mean arterial blood pressure, our aim should be between 60 to 65. And preferentially, we start with norepinephrine infusion for hypotension, since this is there is systemic inflammatory response and infection, and vasodilatory effect. We consider dobutamine in the setting of worsening hypotension with cardiac dysfunction. If still there is no response, you may consider epinephrine and vasopressin should be considered for refractory hypotension. Next slide. And here just to mention that in case of difficult cases, which is you are not able to manage properly, and you may need even to have a fluid challenge, which is also should be used very carefully. Pulmonary catheter or wedge checking may be helpful, but it should not be routinely done. And I usually like this slide. This slide to differentiate between patient coming with acute heart failure. You look for two things. You look for congestion and you look for hypoperfusion. And you have four categories for such patient. Either the patient congested, and that is wet, and hypoperfusion, maybe he's hypoperfusion. If there's hypoperfused and no congestion, this is coming the lower left corner, cold and dry. And if he's wet or congested and hypoperfused, it will be cold wet in the right left corner, down bottom. And if he's not hypoperfused but he's congested, then he will be warm and wet in the upper right corner. And our aim should be warm and dry in the left upper corner. So with deciding clinically which area is your patient is, will decide how to manage him. Okay, go to the next slide, please. And here there is a treatment which is done. We said that inotropes, antiviral drugs like lopinavir, ritonavir, steroid is also tried, chloroquine. Initially was gaining ground, but it looks like going down now. And the one study from Brazil is showing the negative result. And we go with the medical treatment for heart failure before we discharge patient at home with drugs which showed survival benefit. Next slide, please. And what is the goals and aim of treatment patient with acute heart failure? Next slide, please. There is immediate and there is intermediate and there is before discharge. The immediate goals, we have to have a safe practice and protection for medical staff. We have to treat a reversible cause as per guideline. If you have STEMI, then patients should, some patients they treat with, go to primary PCI, depending on the situation, or you give thrombolytic therapy. And after definitely doing an echo, but always protection is number one. We have to improve the organ perfusion and hemodynamics. We have to restore oxygenation. Patient may even require intubation. We have to help alleviating symptoms, fever and others. And we have to limit the cardiac and renal damage. Next slide. The intermediate goals, we have to identify the etiology and relevant comorbidities to address them. We have to titrate our therapy to control congestion and optimize their blood pressure. And we have to initiate inside the hospital if the patient improves, and up-titrate disease-modifying pharmacological therapy, which shown in clinical trial with survival benefit. And later on in the follow-up in the clinic, you may consider device therapy in appropriate patients. Next slide, please. The pre-discharge and long-term management, we have to develop a careful plan that provides a schedule for up-titrating and monitoring pharmacological therapy, need and timing for review for device therapy, and we should arrange who should see the patient, and preferably patient should be within 1 week after discharge. And if we have program looking after heart failure, as we have here in National Guard, like the cardiovascular disease program, we should enroll them in that clinic and should be seen by the nurse practitioner before discharge, that to help in preventing early admission and to improve quality of life and survival if possible. Next slide, please. So when patients come to you acutely ill with COVID and heart failure, definitely you're going to treat the COVID, as we mentioned earlier, with all in your hands, whatever getting evidence, because the evidence is evolving. Every day we have a new information about the COVID-19. So it's going rapidly. You have to follow day by day. So you look to your patient, is he in cardiogenic shock? If it's yes, then you support him with circulatory support, pharmacological or mechanical. If it is no and had respiratory failure, if it had respiratory failure, then you go for ventilatory support. But always you should avoid aerosol generating any procedure which generate aerosol, because this may cause even increased chances of infection. The patient should go to the ICU or CCU, and immediate phase we have to look for the etiology, including infection. So we have to address it immediately, and we have to initiate specific therapy, and we have to follow up the recommendation. And we go with the diagnostic workup to confirm acute decompensated heart failure, and we have to rate accordingly. Next slide, please. Okay. And assessing patient bedside and hemodynamics, we look, as I mentioned earlier, for presence of congestion. And usually acute heart failure, they are congested. Almost 95% of patients are congested. Dry are only 5%. And the worst situation you may see, this is the wet and cold, because he's congested and hypoperfused. Okay, and this slide you can go through it. Is repeating of similar, but it directs you how to manage your patient steps wise. Next slide, please. Is the role for any mechanical circulatory support? ECMO is tried in Wuhan and some areas, and the placement of ECMO for critically ill patient outbreak was tried in Wuhan. The treatment of critically ill patients suffering from lung failure, the ECMO works as an artificial lungs or artificial heart also, and replace the patient lungs seriously damaged by the virus, providing continuous extracorporeal breathing and circulation, just to buy time for the patient to recover and for the treatment to take action. Next slide, please. Okay, ECMO. Should be ECMO considered for all patients? No, we know that resources are limited, so should be given for patients with the chances of recovery, and should not be considered in very futile patient. Next slide, please. Okay. Refractory hypoxemia and respiratory acidosis despite advanced ventilator management. In this patient, we should consider VV ECMO via internal jugular vein access is the most appropriate. Next slide, please. In patient with significant cardiomyopathy and cardiogenic shock, a V ECMO, venous arterial ECMO, is configuration might be necessary. Additional data regarding the ECMO outcome is needed, because this is just recently tried in patient. Okay, next slide, please. As the majority of patients with circulatory failure also have profound hypoxia, the utility of other cardiac support devices, such as intra-aortic balloon pump, tandem heart, or impeller, is limited. Although I came through the people who tried intra-aortic balloon pump. Next slide, please. This is just for VA ECMO figure. Next slide, please. And this is the figure for intra-aortic balloon pump, circulatory support. Next slide, please. And this is just for impeller and tandem heart. Next slide, please. Okay. The diuretics is not different from all the clinical trial. Either you give it in form of infusion or in form of policies. Okay, but the guideline, if patient is not in circulatory, in vasodilatory shock, then you can make him dry as quickly as possible. But diuretics in case of COVID-19 should be done very carefully, as well as the fluid, because patients sometimes here have circulatory. That is why sometimes if it's difficult cases, you need to have a pulmonary catheter and checking the wedge to which direction to go. Next slide, please. The common drugs, this is at the end of the patient before discharge, diuretics initially on the management. And there is, this is RAS inhibitors, ACE inhibitors, angiotensin reverting enzyme, angiotensin blocker, and the aldosterone antagonist. There is a lot of talks because there is upregulation of ACE2 receptors in patients with taking such medications. Initially, they thought there is a harm, but there is a clear guidance from all the societies. I'll mention it later. And so they can be used. RNI, this is cyclobutyryl valsartan, and beta blocker should be always considered before discharging patient. Anticoagulation for as a prophylaxis is needed. And some people are speaking about therapeutic, but need a lot of studies. This is a question which is raised initially. Next slide, please. Should inhibitor of renin-angiotensin system be withdrawn in the patient with COVID-19? And there is next slide, please. And there is a statement from the American Heart Association and Heart Society of America and other society, European Society, Canadian Society, and Hypertension Society. All of them, they agree that continuation of RAS medication, ACE inhibitors or AR medication, RNI medication for all patients is already prescribed for indications such as heart failure, hypertension, should be continued, should not be withdrawn. Next slide. What are the criteria for discharging? If we manage to bring the patient in a good state, so before discharge from the hospital, we have to ensure certain criteria. Patient admitted with acute heart failure should be medically fit before discharge. We should ensure that he's hemodynamically stable, euvolemic, okay, and he's on evidence-based oral medication and had a stable renal function for at least 24 hours before discharge. And we should tailor his medication, and we should educate him about self-care. Before discharging him, as I mentioned earlier, we should enroll him in disease management program and should be seen by a physician or the clinic within 1 week after discharge. Next slide, please. To conclude, at the end, there is a take-home message. Clinical trial is required for finding for appropriate treatment for COVID-19 and cardiac involvement. Work is going on for finding vaccination, infection control, hand hygiene, social distancing are encouraged for the time being. Next slide. Cardiovascular involvement is common. Cardiac involvement associated with worse prognosis in COVID-19. Pre-existing cardiovascular disease may contribute to adverse clinical outcomes in COVID-19 patients. Next slide. So we strongly discourage the discontinuation of guideline-directed medical therapy. You mean that the ACE inhibitor or RNI in patients with heart failure or hypertensive, because the upregulation of receptors, ACE2 inhibitor receptors, even in notice that in some it's maybe protective for the lungs. Next slide. And to conclude, we should not withdraw the heart failure medication. We should ensure that patient on all heart failure medication before discharge. Thank you very much.